Hello, welcome. Rick Bukata, Risk Management Monthly, coming to you. My guests, as usual, Rachel Lindor, broadcasting from Scottsdale, Kevin Klauer from Ocala, Florida, and yours truly from this week. I'm down the street from Rachel in Scottsdale. Hey, listen, we got a bunch of stuff to talk about this time. These are all from in the news section of Risk Management Monthly. We're going to pick up right away, except if you have any opening remarks that you'd like to make. I know Kevin just went through the horrors of a joint commission. He won't say that because he used to do politics, but I hated joint commission. You know, I just couldn't stand it.
Well, it was just anticipating when the visits were going to occur. Once they got here and we could demonstrate the great work that our teams here have been doing in preparation, and every day it was just a breeze. Both of you, don't worry about it a bit.
And now, Rachel, you're going to be in charge of that
Nope.
at your hospital?
No, I will not be. Thank you very much.
Well, it's flattering to be offered.
I guess so, but
You didn't perceive it that way? Rachel was offered to be in charge of that kind of stuff at her hospital.
but will not be stepping in. Thank you very much.
I was wondering what you did wrong. Okay, let's get started. States take action against nurses who tied to. Can I read that? States take action against nurses tied to degree scheme. Yeah, you've read a lot about this. You heard a lot about this, where these nurses, particularly in South Florida, why is all the fraud in South Florida? It's like all the Medicare fraud is in South Florida.
Let's ask Kevin.
Well, I wouldn't know. It's a big state, and I'm in Central to North Florida. So yeah, I'm not going to respond to that one, Rachel. Thank you. I know I'm closer than you two, but I'm not close to the fraud.
They basically talked about these three shuttered nursing schools who were the students were paying between $10,000 and $15,000 to fake that they got degrees from these schools. And once you had a degree, then you were entitled to take the National Council licensure exam. So that got you so that you could now work in hospitals. About a third of those who, this is fascinating. About a third of the people who bought the fake documents that said they went to nursing school passed the exam. Now, what does that say about this exam? That they passed without, proper preparation here.
Well, it's pretty scary, Rick, because also it's 2,800 nurses that were likely to find employment and licensure.
Yes, that's coming up too, because what is the hospital's responsibility now that these nurses are on their staff? Was it appropriate they check whether they completed nursing school, or just was it reasonable to say, do you have a license and we can verify your license? There are a ton of states that are involved in 8 states have disciplined nurses. There's a bunch of other states which are investigating this. Only 2 states say it's fine here, no problem, Wyoming and Arkansas. So the vast majority of them are going to be looking into this, as I think they should. I mean, this is a large number of nurses disseminated across the country. Any thoughts?
Rachel,
it's okay, Rachel.
You go, Rachel.
I mean, I was pulling up some stories to see, is this a one-time thing? And actually it looks like there's, been historically a large industry around fake diplomas, and, it's not unique to medicine. It's not unique to nurses. There's kind of diploma mills for pretty much any industry. And I was interested in figuring out what are the repercussions for this, and is it, criminal prosecution, and how deep can it go? And I got a little bit lost in the weeds there, but it looks like, for pretty much any industry, you can get a fake diploma. And then if you're found out, authorities can press criminal charges against you for fraud. But with medicine, I think the risks are greater than that, because not only can you be charged criminally for fraud, but then if you injure people in the course of committing that fraud, you can have additional charges added on to that. And so these nurses and physicians have done this too. run that risk. If they're in the act of committing that fraud, they injure somebody, they could be charged for, felonies, manslaughter, et cetera, and kind of go down that rabbit hole, which is significantly more dangerous. And there's definitely precedent for that. So, what the liability is for the hospitals and such that hire these people, I don't know. I guess I'd be speculating, but I think certainly it's there. But apparently there's a huge industry for this. So sorry.
Yeah, you're exactly right. I mean, and you mentioned that before, and I was just going to emphasize it. In this particular instance, between 2016 2021, $100 million. This was a fairly lucrative effort for these people. And how much effort actually do you have to put forth to create fake degrees and find people who want to capitalize on them? I don't think it's a very expense-heavy industry. But a very lucrative. So I think it will probably happen again. Pretty impressive, that's for sure. And you're exactly right. I think the downstream consequences for the individual, but also most importantly for patient care, are really, really serious.
I found an article that talked about some of the consequences. This is 5 lawyers commenting on what could happen here. They basically say that the hospitals technically have employed unlicensed providers, because although these people have a license, they earned it fraudulently, and so that they really are considered unlicensed. And so they're providing services in the hospital with these unlicensed folks, even though the hospital really might be quite innocent in terms of it did its due diligence looking at that these nurses were licensed. They point out that the hospital has the obligation to verify a nurse's competence in performing essential functions independent of the fact that they have a license. They need to take a look at how they're performing at the hospital, and that they have a duty to identify and terminate the employment of unqualified nurses, even in this era of we got to have nurses. And so even if they're established at your hospital, but certainly new nurses who are coming on, careful evaluation of prospective hires, even amidst the current nursing shortage. So that's kind of the recurring theme here, is that if you have some process that will periodically evaluate a nurse's competence, that would certainly sound like an augmentation to the case that you did the best you could.
Yeah. And I think that's a take-home point for, folks that might be listening, if they're in positions to be hiring, whether it's, nurses, other ancillary staff, other physicians, that understanding that there are the risks out there for people to be using fake credentials, and that potentially you as the employer could have liability in that case, even though they are the ones committing fraud. And the way that you would protect yourself from that liability is to be demonstrating that you have processes in place to do your due diligence to be verifying their credentials. And while that might not protect you 100%, having those processes in place does provide you probably some protection in those cases. And that's the best you can do.
Well, I agree with you, Rachel. And to further go into it in a little more detail, I mean, you have a duty of care that is expected with hiring, and there's a standard that has to be met. And if you don't fulfill that, there is such a thing as negligent hiring, and you can be held liable for that. And even if you were fooled, that is just a fact that helps mitigate your liability. It doesn't absolve you of your responsibility and the standard of care that you have to meet to fulfill the duty that you had to others by credentialing these people or certifying their backgrounds appropriately. Look at this, even the conditions of participation, nursing services from CMS, 42.23, not that anyone wants the exact citation, but the hospital must have an organized nursing service that provides 24-hour nursing services. I won't read the rest of it. Well, it doesn't say anything about fake nursing services. They have to actually be true nursing services. And having just gone through, a Joint Commission survey, if the Joint Commission is doing your CMS inspection as well, they do both. Well, you also have to meet those requirements to make sure that there is verification of the credentials that the person is putting forth. As Rachel said, if you don't have a good process in place, it's a problem. Even when you have a reasonable process in place, you can still make errors, but it is still your responsibility to do the right thing.
Yeah, I can guess you can get into the issue of fraudulent billing. because services were provided by a non-licensed person. So it could be a mess. And I wonder how you find these 2,800 nurses scattered around the country who are probably not likely to be coming forward and say, oh, I'm one of them, you know. So they're going to be kind of like a needle in the haystack. Rachel, I realized that I basically screwed up and stole your thunder by taking that. I thought this was a separate paper, but it wasn't. It's written by the same person, and I apologize.
I was really offended.
Let's go on. This is next one is a kind of a interesting one in emergency medicine.
Yeah, this one's a hot topic for sure.
Kevin, this is non-compete agreements.
Yeah, I mean, it definitely is hot in emergency medicine. It could be hot elsewhere too. And just remember the underpinnings of this in the past was really to make sure that you could protect a very narrowly defined and tailored business interest. And I still think the purpose of non-competes makes sense as it reads. You know, if you start a group and you don't want someone to steal that group because you put so much at risk, well, you know, any narrowly defined business interest should be protectable or could be protectable to a certain degree. Now, take it to modern day times. No, that's not what has happened. There have been some groups that haven't allowed people to work in any hospital in any state they're in. So it's crossing state lines. Most of these are unenforceable anyway. And matter of fact, Rachel, you may have different experience. I haven't seen anyone try to enforce a restrictive covenant or non-compete in any recent years. It is really a signal usually to tell people what they shouldn't do. But as far as your true exposure to this being executed on and enforced is probably unlikely. But the FTC, you know, they came forward with this new subchapter, Part J, Part 910, under Section 5, if you want to look it up. Okay, so subchapter J, Part 910, Section 5, where they say, listen, you can't do these things. It's not fair. And I tell you, it would be a great win for a lot of people who want to move freely from one position to another and not be restricted. I tell you what, a lot of employers are probably very nervous right now. Without going into too many details, I do want to share some of the details of what's being proposed. And a couple of them are, they define a non-compete clause as a contractual term between an employer and a worker that prevents the worker from seeking or accepting employment with a person or operating a business after the conclusion of the worker's employment. Okay, that makes sense. That's the way we've always understood it. And they've also said that they will even rescind existing non-compete agreements within 180 days of publication of the final rule if this goes through. Could you imagine that? And I think that will be subject to some degree of litigation because a part of your contractual terms of employment is a bargain for exchange, including what some of your restrictions may be. So you're kind of undoing the employment agreement, which is fascinating that they think they're going to be able to do that. I would like to see where that goes. And are there any exceptions? There are a few exceptions, which makes this fairly reasonable. Restrictive covenants other than pure non-competes. So anything else that you want to restrict other than saying you can't go work for a competitor, you can't go work across the street, you can't go work wherever. Anything other than that is not subject to this this regulatory language or piece of legislation. Confidentiality agreements are not subject to it. Fixed term employment contracts. So basically, in a nutshell, if the contract term ends, this is from their language, the former employer can sue the departing employee for damages arising from the contract breach, but cannot bar them from taking a new job. Well, I don't know anyone that was ever prevented from taking a job, at least not in medicine, not in emergency medicine. And I don't think anyone is going to sue you for damages. What damages would there be for you to go take another job? So I think this is still very helpful to the practicing emergency physician. So that's a quick summary of what it entails, and it'll be very interesting to see where it goes. There's great support for it right now.
Yeah, there is certainly in the emergency medicine community, that's the case. And I'm sure that the ACEP people are talking to their lobbyists in Washington about making sure that this happens. But I'm sure a lot of much bigger industries are involved in this as well.
Yeah, I mean, I think this is a huge deal. I haven't seen numbers for how many emergency medicine contracts have non-compete agreements. I know I saw a number for family medicine jobs. It's about 40% of those, which makes sense just given the nature of that industry where non-competes would be, you have a patient base and it makes sense to have some prohibitions against competition where you're trying to protect your clientele a little bit more than in the emergency medicine community. I also haven't seen non-competes enforced recently in emergency medicine. I kind of scoured the literature for a recent talk and found one case in emergency medicine where they did take somebody to court who had signed a non-compete agreement saying he wouldn't work in an emergency department in his county or a neighboring county for a period of 2 years after he left his job. And he quit and he went to the neighboring emergency department and they took him to court. And the trial court said, you've got to fork over however much cash was in the non-compete agreement, and went up to the appeals court and they reversed it and said, this makes no sense. It's not reasonable, which is kind of the language in any non-compete agreement, has to be reasonable to protect a business interest. So they reversed it and basically said what I think everyone thinks, which is non-compete agreements are really not reasonable in emergency medicine. So that was the one and only example I could find of a non-compete in emergency medicine being taken to court in recent years. And they ended up saying it wasn't reasonable anyway. So
I think they're going by the wayside. They're still out there. I've worked for a variety of different employers and different groups. Some have had them, some have not had them at all. And you would be amazed and surprised who those groups might be, because some people just fundamentally don't agree with it and know that it's certainly a negative thing for physicians and other clinicians. And there's no benefit to it because, again, the effort to make it enforceable would be a challenge. And boy, what the negative publicity for you doing that is not positive for any group as well. So I don't think that people really want to enforce these.
But I think the language in here that takes them out is so important, because so many people have signed contracts that have them, and us saying, oh, they're not enforceable anyway is almost meaningless to the people that have signed the contracts with them, because they are not going to have a non-compete and then go violate it, because that's just against so many people's nature. So that would give them so much anxiety that they're doing the wrong thing, that they are potentially setting themselves up for a lawsuit. So even though they might hear it's not enforceable, they're going to take it at its word, and it's essentially being enforced anyway, which is what all these groups want.
Yeah, you're right. You're right, Rachel, that if anyone has integrity and they agreed to the terms of the contract, they should try and abide by the terms, whether they're enforceable or not. So probably you and I would look at it the same way. Has said I wouldn't do this. Now I'm in that situation. I probably shouldn't do that. So I agree with you that I think it still has its effect, although the effect is significantly diminished by its outcome if people were to decide not to follow it and see if they were going to get challenged on that. It's pretty unlikely that anyone's going to spend money and time pursuing an individual physician, except for the case that you mentioned, to try and enforce this when we know that there isn't much case law to support enforcement.
Well, non-compete agreements were common in emergency medicine. Some of the groups would distinguish themselves from their others by saying we don't have non-competes. I remember Steve Dresnick was one of those groups that says we never had non-competes. And I think non-competes in California, I think that they're not. I don't know if the term is that you can't do non-competes in California, but that's what I heard.
That's true.
It is true?
What they're proposing, as I understand, because they cited it in a summary article, is to be similar to California law. So you can the fixed durations are permitted, but in this exact way. So exactly the way California does it.
We're always ahead of our time.
Of course.
There, So you're gonna get after now is you're gonna get our taxes. You're gonna get our tax rates.
California is often cited as the role model for this specific issue because of like the success of Silicon Valley, and that's often credited to the fact that they did not have non-competes, because back in like the 70s, 80s, the technology sector was actually, it was more successful and kind of off to an earlier start in the East Coast, but they had the environment there is that non-competes were really strictly enforced. And then California, it was not, it was off to a slower start, but there were no enforceable non-competes. And so there was a lot more mobility between workers in the technology sector. And that's often credited with how people bounced around, started new ideas, like took ideas from one place to the next and built off each other. And like, then there was Silicon Valley, whereas like nobody's ever heard of whatever it's called over in Massachusetts that, fizzled out because people couldn't do that. And so a lot of the time in these discussions about let's get rid of non-competes, you find, at the root of that is like Silicon Valley held up saying this is why we don't want non-competes in this country because of Silicon Valley. And so California is like the thing that we look at as, what we're trying to emulate.
That makes sense. One additional comment I would have is that if you really look at the impact and right or wrong, good or bad, it's oftentimes not when someone's leaving to go find another job. I think that is the least likely time to really enforce that. But when a group, whether it's a single contract group or it's a contract management group, loses the hospital contract, well, the part of the value of their presence there is the staff that they bring. So can a clinician stay at that facility or not? With a non-compete, they have to be released technically if they're going to try and work there, and it's going to be enforced. And that is just a disincentive for the hospital to just quickly change hands, thinking they're just going to keep the same staff. Again, no comment about right or wrong, good or bad, but just thinking about different ways this legal instrument can be used.
Moving on. Can a state's Medical Malpractice Act apply to non-patients? This is the question that was addressed in a case in Indiana, where a woman on multiple medications, including an opiate, was driving toward an intersection when she yelled to the passenger that she could not get her foot off the gas. Quite a problem to have. As a result, there was a serious accident at the intersection with multiple fatalities. The woman driver died, but this involves the case of a woman that she hit. She died as well. So the husband would like to sue the doctor because he made various claims, like failed to warn the patient of the dangers of operating a motor vehicle under the influence of prescribed medications, failed to screen the patient for cognitive impairment caused by the medication, failed to adjust her medication to address problems with muscle control, and asked the state's motor vehicle bureau to assess her driving capability. All of those things were viewed as negligent, that they were not done. And this husband of the patient who died wants to sue the doctor in this accident. This is according to the state of Indiana. You can do this now, and this is considered a malpractice case. However, the physician ultimately settled for the state's limit of $250,000, and this is one of the states where they had a patient compensation fund for money to be paid over that. The patient's husband, who died, subsequently filed a lawsuit seeking excess damages from the fund, but the fund administrator responded that the fund had no obligation or liability because the underlying claim was not covered by the state's Medical Malpractice Act. So the long and short of it is, and this is one of these state by state kind of things, I guess, but it seems like it was perfectly reasonable for this person to sue the physician who he believed was responsible for the behavior that caused this person to cause an accident that killed his wife. What do you think? Yes? Is that a reasonable thing to do? Or is that not not? Well, now that it's unanimous.
Well, I'll jump in just quickly. And I know that Rachel will give us great perspectives on this, but some of this comes out in the facts of a case. Is there really liability? Well, you're going to have to see exactly what exactly what the facts are based on the alleged negligence of the hospital clinician, whoever the defendants are. But I think this really focuses on the unnamed third party. What is your duty and obligation to protect people from this person? Protect people that you don't even know. So if you send somebody out completely intoxicated on any substance and it was at your hand, well, there have been some cases that suggest that you do have liability to an unnamed third party. This person's driving normally otherwise and wasn't impaired and happened to have been driving and got their foot stuck, and they were, reasonably using the medication that shouldn't cause this kind of problem. Then no, I don't necessarily think that you would be found to have liability for this. But the unnamed third party is a real entity that we have to consider as having an obligation to, if there's obvious risk to them based on what we know of a patient before we discharge them.
Rachel?
All right. So, yeah, I mean, I think the danger of this case is that it can cause people to get worried all of a sudden that their liability is going to be expanded to, all of these unnamed third parties. But I think you have to look at the context of this state specifically. And when you do that, you find that this is very much specific to the Malpractice Act within the state of Indiana. And that, for people within Indiana, sure, they're going to have some liability for unnamed third parties, but for people beyond that, it's kind of irrelevant. So in general, physicians have a duty to their patients and not really to anybody else. The major exception to that came in that really famous Tarasoff case where the psychiatric patient made a threat to a named third party, basically said he was going to go kill his identifiable student in his class. And then the psychiatrist didn't warn that student and he went and killed them and something like that. I might be screwing up the facts. And the court said the psychiatrist should have, had a duty to warn that student. And that was life-changing for physicians everywhere, because now we have a duty to warn third parties that we can identify if there's an identifiable, threat to them. So it's to identifiable third parties. We do have a duty. So not just to our patients, but identifiable third parties. And that was kind of like a big crack to our duty to not just patients, but identifiable third parties. And that's kind of where it's been left. So this case, is confusing because now Indiana is saying, in this case, there was malpractice. There was a duty not just to the patient, but now the husband of somebody got hit by the patient. So that's weird. So looking into this, what happened is in Indiana, what they say for this Malpractice Act, they define a patient differently. They say a patient of a physician is not only a patient in the traditional sense, as we understand it, of a person that the physician is treating, but also by their definition is, let's see, I wrote it down here. What they say, a quote, a person having a claim of any kind, whether derivative or otherwise, as a result of alleged malpractice on the part of the healthcare provider. So they provide a secondary definition that really broadens the definition of a traditional patient. And when the court looked at this, that appeals court, to decide, did this husband of the person who is hit have a claim? They said, we're providing two definitions of a patient in this Malpractice Act, both the traditional patient, as common law everywhere defines it, and also secondarily, any person having a claim of any kind, whether derivative or otherwise, as a result of alleged malpractice on the part of the healthcare provider. And that's what this husband was. So that's very different than the definition of a patient that we see in, case law from all these other states. So if you don't live in Indiana, you're not subject to Indiana's Malpractice Act, then the finding of this case is kind of irrelevant to you. And, if this happened again in Arizona, Minnesota, Florida, California, I think the outcome potentially is very different.
Makes sense. I would be mindful, because it's probably good practice, that as you said, don't be afraid of people just suing you because your patient happened to do something to them. But if you really create an unsafe environment that puts other people at risk, it's not a good idea to take the chance. Not good for your patient, not good for who they may harm. And I think it's probably wise to just consider that. And the example I'll bring up again is just the really unsafe discharge, somebody who truly is unsafe to go. And I think you may prevail in a claim of this type, but you'd rather not be there at all. You'd
I
rather
think,
be somewhere
yeah.
else.
I'm not sure it would be malpractice, you know. I think it might not fall under the realm of malpractice though, as far it like I wonder if it would be under a different umbrella.
Well, yeah, no, I don't think it's malpractice, but I think it's negligence. And
Right.
how so you're exactly right. And that's why I feel bad for so many physicians. I tell you what, I thought this early on in my career. Okay, so negligence is only medical malpractice. I didn't realize, that there are many, many forms of negligence and many standards many standards of care to fulfill a duty that you're going to have to abide by. This would be a different duty, of course, and it would be a different standard of care. But I would just rather not have any one of our colleagues be in the position of defending this. So don't send somebody unsafe home if you can avoid it.
It's almost worse that it would fall outside of the outside of the malpractice umbrella, because then your insurance wouldn't kick in.
Could be dangerous for a lot of reasons, for sure.
Right.
Yeah, you would seem that it's just a regular old liability suit for money would be between the one family who had survived and the family of the person who was responsible for the people's deaths. I mean, that would just be a nice straightforward, not medical liability just a simple lawsuit, not criminal but civil.
Well, reading about this also goes back to one of the things I harp on, or that one of my practices. I harp. Yes, I harp. One of the practices that I try to maintain, and that this will help me continue to maintain. When I prescribe opioids, I always have a discussion with the patient about, things that they shouldn't be doing while they're on opioids. They're sedating, they're constipating, they can't drive while they're taking opioids. And, sometimes it gets to be a very boring conversation. I wonder how many people are listening, and then I document that. And, maybe that takes a dot phrase. It does not take very long, but basically what was litigated here is, so what happened is this old lady had been prescribed opioids for years, and the dose hadn't changed, but she was driving in a car, I think with her grandkid, and ran a red light. And the car that had the right of way, she hit, and she killed the mom and the daughter that were driving through the intersection. And so the husband sued and said, she was so sedated on those opioids that she couldn't lift her foot up. And there was no documentation that the prescribing physician ever warned her about the risk of driving on opioids. And so presumably all it would have taken to prevent this lawsuit was some documentation that discussion had occurred, and leave it to what you just suggested, Rick, as a lawsuit between the driver and the husband to say, the doctor did his due diligence and said you can't be driving on the opioids, but there was no documentation to suggest that he'd ever had that conversation with her. So I think, that's another take home point that we could get from this, is that, it's not that we can't prescribe opioids, but we have to document that we're having those clear conversations with the patients that you can't be doing these things. Driving under the influence is not to be done, and they're assuming the liability for doing that, not us.
No, you're exactly right. And I think, obviously, I mentioned earlier, there's somebody obviously impaired. Well, you don't certainly let them go out if you can avoid it in any way, shape, or form. But you hit the nail on the head. If we advise them of the risk, that's the broad definition of the unnamed third party. You can't send an email to everybody in your community. You can't rent a billboard and say, this person is out there, I'm protecting all the unnamed third parties. You tell the person, don't do this. We've done this for years, which is appropriate for patient care, public safety, and for risk mitigation, is seizure disorders. New onset seizure, what is in all of our discharge instructions? Don't drive. You might hurt yourself, you might hurt someone else. This is specifically for this purpose. And you don't necessarily have to counsel them, but as long as they acknowledge their discharge instructions and sign off on them, I think you've met the obligation.
You see some of these instructions that say, don't drive heavy machinery.
Yeah.
Like, is that a D10 bulldozer? You know, what if it's a very small car, you know? You guys know about Kowalski? Rachel, you know about Kowalski? It's a New York case where they basically, no, you don't? Okay.
So,
This is a New York case where the patient went out in inappropriately in terms of clearance and
walked across the street.
Yeah.
yes, and there
I
was
know,
Yeah.
know it well.
Yeah.
well, why don't you summarize it for us, Kevin? Because it's a little different.
Yeah, if I recall the facts correctly, and I think I do, this patient was held in an ED because they felt that the person was suicidal. He said no. It might have been suicidal, might have been ETOH intoxication, or
Yes.
both. But he said, "Listen, I'm not. I'm going to go." And ultimately, they decided that he had the capacity to refuse. They let him go. He walked out in front of a car, and I think was significantly injured there. So that this was a significant case. That really, if I recall correctly, ruled then for the plaintiff, because they should not have let him go, even though this guy said that he should not be held and had the capacity to consent and refuse. You can fill in the gaps, Rick. It's been a while since I've looked at that case.
Yeah, I thought it was the other way around. I thought they basically said you could let Kowalski go.
Well, maybe they did. Maybe they did.
That
Because
was
the concern is on both sides of it for sure. Let me look it up. We'll figure it out in a second. But maybe Rachel remembers
you know,
it.
Rachel's
I'm
our
looking it
data
up right
person.
now.
Come on, data.
I'm looking it up right now. So he was intoxicated on his previous visit. He'd been suicidal, but there was no evidence he was suicidal on this current visit. He was just drunk, garbled speech. Blood alcohol was 0.369, but alert, able to walk, seen by the ED, accepted to a detox facility, but waited for 4 hours, waiting for transport. Took out his IV, told the nurse he was going to go home in a taxi. She said, why don't you get a friend to pick you up? He agreed. But again, said he wanted to leave. When she came back, he was gone. She asked if she should call the police. Doctor said no. They notified hospital security. Plaintiff left unescorted, was hit by a car an hour or two later. Plaintiff sued the hospital, the doctor, for negligence and medical malpractice. And then let's see, the Supreme Court, the appellate division reversed and held that the defendants, so the hospital, had shown that they lacked the authority to confine the plaintiff upon his departure from the hospital, and that the plaintiff had failed to contradict that. So basically, the plaintiff's claim was that the hospital should have prevented him from leaving, and the court said the defendants had no right and therefore no duty to do so.
You were right, Rick.
So this is a dangerous kind of rule and regulation that basically says you can't hold people who want to leave. And there may be some, which is just the opposite of what we believe. We believe that we should hold people who have the potential to harm themselves or others, and that we can, you know, sedate them and whatever we have to do to hold them. The state of New York, apparently it's a little different. That these
Well,
people,
it's different. They have this mental hygiene law. Remember, we talked about this before, and New York has they have a mental hygiene law that's specific to this. I can't remember the nuances, but it's different in New York.
all right. Well, I'm sorry talking about the thing in the first place.
No, it's a good case. Good to bring up, good discussion.
Rachel, you want to tell us about these paramedics?
Do you want me to finish this case and
I
talk
thought we
about
did.
New York's mental hygiene law?
Okay.
Okay, so the mental hygiene law specifically, this is in New York specifically, it addresses a question of when a hospital may retain a person who's drunk, essentially. Basically, it says if they come into the hospital voluntarily, it deals separately with somebody who's brought voluntarily or involuntarily. So if they're brought voluntarily, if they're brought involuntarily, they can be retained for emergency treatment if they're found to be incapacitated. And there's a likelihood there's likelihood to result in harm. Let's see. They're incapacitated to such a degree that there is a likelihood to result in harm to the person or others, or a likelihood to result in harm to oneself, manifested by threats of or attempts at suicide or seriously bodily harm or other contact that demonstrates a danger to self-injury. For people that are brought in involuntarily, like the plaintiff, or sorry, for people who are brought in voluntarily, like the plaintiff, there is no provision for involuntary retention. So because he was drunk, but he came in on his own accord, it does not allow you to keep them against their will.
Right.
So that's why they said the hospital had no right to keep him, even though he was so drunk, that.
So you wonder how a jury of people are going to, you clearly broke the law, doctor. You let this person go home. Our law says that's allowed. But a jury of 12 people, I think, would have a hard time upholding that, depending on the jury instructions, because nobody in their right mind would think that would be a reasonable thing to do. This person is clearly intoxicated. Yes, he did come out on his own, but now when you came in through those doors, I am responsible for what goes out those doors. And
I don't know that it even goes to a jury in New York.
No, but I'm suggesting that what would happen if an ER doc was charged with letting somebody go home and they potentially hurt themselves. I think a jury basically, if they were suing the doctor, would have a hard time supporting the law.
Well,
Because
I think New
anyway.
York is specific, because in New York it's very clear that the physicians in that case, their pathway was decided for them. They followed the law and the law was black and white. But New York is, not, I don't know if it's unique in the country, but most states do not have it mapped out that clearly to say, if you come in voluntarily, you must be able to leave voluntarily. Most states, as soon as somebody walks in and they're drunk with a BAC of 400, then
you're
it
ours.
becomes very gray. To some extent.
We own you.
So anyway, I don't know how we got on this topic, but
it's a good topic.
I blame Kevin.
I will take the blame for that. And I will say, as we depart from this, I no longer have the capacity to consent or refuse the discussion on this topic, but that's where you protect yourself, I think, in that person with that alcohol level of 400 or whatever it is. You know what? You don't seem right to me. I don't think you have the capacity to consent and refuse. Therefore, I'm not violating your rights and I'm not violating your ability to make a decision here, because you don't have the capacity. Document it well in your medical record and you're in much better condition then.
Now, Rachel, do you want to tell us about the paramedics?
Oh, yes.
First degree murder.
All right. So this case is similar to one we did a month or two ago, but is apparently different. So, but striking in that it's similar. So this is apparently happening again over and over. In this case, there was a patient who was in his residence or somewhere similar, and EMS was called because he was suffering from alcohol withdrawal, hallucinating. EMS arrived. They tried to encourage him to come out to the ambulance. He was not able to, so they ended up having to put him on the stretcher. And again, because he wasn't cooperative, he ended up on the stretcher in the prone position, and they had to strap him down on the gurney and basically, kind of tighten him down on there with the straps across his back and his lower body and transport him to the hospital that way. And when they got to the hospital, they essentially realized that he was dead and had essentially asphyxiated. They did an autopsy, and the autopsy read asphyxiation, positional asphyxia, thought to be secondary to just compression from being proned with the straps. And again, this is essentially the second case we've done from the same cause of death, from basically an uncooperative person being put in a prone position and then not being monitored appropriately. And these folks that were involved, the EMS folks, are charged with, you said, first degree murder charges and out on $1 million bond right now.
I like the quote of the of one of the paramedics. It sounded like he or she was kind of bummed. You're gonna have to walk because we ain't carrying you. I'm seriously not in the mood for this shit. Oh, dumb shit. So it was a really a warm therapeutic relationship that had been established between the patient and the paramedics. But this stuff is kind of like so obvious that should not be done. And this is not the stuff where you restrain the people's arms behind their back to their ankles. What is that called where they do that?
The hog tie. The hog tie.
Yeah, that one clearly you're lifting, you're all in your chest and trying to lift your entire body weight each time you take a breath.
Yeah.
But $1 million bond. I don't know why this would have been considered first-degree murder, though. You law people, doesn't it involve intent?
Well, it depends on the individual state, how they define it. As Rachel eloquently stated before, with the unnamed third party case, there are some nuances, but the first thing is, I think a lot of people think, well, if this is in the course of medical care, this can only be a civil liability, can't be criminal. Well, no, if you meet the elements of a crime, you certainly can be charged with a crime as well. We know this is not a good idea to do this. We know that this is bad practice. This is so egregious that, yeah, you might meet an element for a criminal fine. This is very reckless. And this certainly is something that you should have known would have caused harm. But I can't get to first degree murder, although I haven't looked at it in the particular state. Generally speaking, you're right, Rick. It requires the intent, not just the intent to hog tie or the intent to restrain someone in an unsafe position, but the intent actually to commit the act of murder.
Right.
So, wow, I think first degree murder is a bit of an overstep here, despite the fact that there probably is room for a criminal charge here.
Right. There are these cases, we've done a few of them before, particularly in anesthesia, where you have a group of nurse anesthetists being supervised by an anesthesiologist who really is not really supervising, and something goes untoward. And it turns out that there was this case in my former hospital where the anesthesiologist was charged with criminal negligence because it was viewed as that egregious. Another case about doctor PAs and NPs being called. I guess in this case, PAs are not involved. This is actually a case of an NP being called the doctor, and Florida aims to change this.
No, you're exactly right, Rick. And this is not the only state that is going through some scope of practice battles. And Florida has had many. And I'll tell you the history on this too, looking into this particular circumstance, is that I think most recently in 2020, there was a similar piece of legislation that was proposed, and it actually died due to, in second reading, just due to a lack of action. Not that it wasn't supported or it was voted down, it just didn't move on further. So now we have HB 583 that was introduced to the current session of the Florida House of Representatives. And it basically says that healthcare practitioner titles and abbreviations, defining terms, advertisement, and deceptive and misleading terms of false representation. It goes on and on and on, and basically speaks to the concept of false and misleading advertising and it being inappropriate. And what they do is they've added a full section, 456.0393, that fully defines all of this and says who can call themselves doctors and who can't. So advertisement, I won't go into the details, just what we would think it would be. You hold yourself out as a certain practitioner, it's got to be who you are. And basically, this is driven by the physician community, stating that if you call yourself a doctor, you should be a physician. Even if you have a respected doctoral degree, and I think we would all, the three of us would agree, that we respect our advanced practice registered nurse and physician assistant colleagues. They provide great service, great value in the healthcare continuum. They really, really do, and as our partners and colleagues. but what they aren't are physicians. And there is no training standard like that of a physician with medical school, residency training, and board certification, maintenance of licensure, maintenance of certification. If you're a DO and certified by the American Osteopathic Association, osteopathic continuous certification on top of that. So this does not exist in those other professions. And they also go on to say these use of these titles, such as doctor, when you're not a physician, is deceptive. It's not right for patient care, and it's misleading. And they only state physicians should use this. Matter of fact, they even say that chiropractors, even though they're doctors of chiropractic, shouldn't use the term physician. It's basically chiropractic physician. You can't, or a doctor of chiropractic medicine. You can't just call yourself doctor. And I won't go through all the provisions here. It's pages and pages, but they also do specifically spell out if you're an advanced practice registered nurse in these areas, this is really what you have the latitude to call yourself. And I think it makes perfect sense. And there are a few articles out there. My final comment on this is that, you know, in the Nursing Practice Act in many of these states, including Florida, clearly defines, you know, what your terminology should be. There are efforts underway to change those to, especially in primary care areas of practice, when the momentum to autonomous practice has given rights to do so, that now you can also change the title to reflect that you're functioning as a doctor because you have a doctorate degree. Well, just because you have autonomous practice in a primary care specialty does not mean you have the same training and background as a physician. And patients have the right to know what the background is of the person caring for them. And they should know what the exact degree that the person holds who's standing next to them caring for.
Yeah, you can see in the emergency department how that would not be tolerated at all. But you can see other times where in rural communities, the NP over time gets to be called Dr. Sally or, you know, Dr. Bill, when it really isn't that way. But it's a kind of a homey term of we're going to be, it's one that basically kind of says it's a reassuring term, and then the nurse practitioners don't tell the patients, no, I'm really not a doctor. You know, they'll just let it go. And if that's what the people want to call them, then that's what the people want to call them. So I think that there is a danger. We did talk about a lawsuit not too long ago about an orthopedic case, which every time the woman went to the orthopedist, she got treatment for the same kind of problem. And over time, the problem really got worse and wasn't treated properly. And it turns out that the person treating her all along was a nurse practitioner. And yet the patients thought she was being treated by a physician. And that was the basis of the suit. In any case,
this is just a related case that in California, there was a case in which a nurse practitioner who had a doctorate degree was advertising herself as Dr. Sarah, referring to herself as Dr. Sarah. And the state of California brought a case against her for false advertising and ended up fining her about $20,000 in total.
mm-hmm.
And the lawyer tried to argue, well, that's not fair. There's people all over that are kind of doing the same false advertising, but they kind of went after her in particular. But that was kind of their only argument against this, is everyone else is doing it. But, I think potentially everyone else is at risk there. And so California kind of really made the stand that, we're not for this either. So like Kevin said, this is kind of playing out in parallel and slightly different versions in multiple states. And I think will continue to be a hot button topic moving forward.
Yeah, that was a recent case. There is this big drive to have nurse practitioners get doctorates. And now they're going back to school to get a doctorate. One of our NPs went to school where you go for a weekend every other month or something like that. And over a period of time, he
and they're highly variable. Like,
doctorate.
What is a doctorate? It's whatever the school wants it to be. So,
well, the implication is that if you go for a doctorate, you know more clinical medicine, and this doctor had nothing
but
to
you
do with
just said
clinical
it's
medicine.
right. It's not clinical, right? It's online.
It's
So
about leadership or something like that, you know.
right.
Well,
So
and
I think
a PhD or a DNP is not equivalent to an MD, or MBBS, or if there's some other
right.
foreign graduate medical degree that I'm
Right.
missing at this
A
point.
JD is a doctorate, but
Right.
we're not holding ourselves out as doctors.
What about
of
Dr. Jill?
We should be cautious around that topic, but yes, she is not a physician, not a healthcare professional. Fortunately, I think
Right.
her degree is in education anyway. But you
Right.
bring up a good point, Rachel, too, because I know you're a licensed attorney. I'm not. I had chose a different pathway for a healthcare executive JD, never planned on practicing law, wanted it to be a career enhancer. So I don't hold myself out as someone who's practicing law, but I have a legal education that's been beneficial to me, and it's really helped me in risk management and other areas of the practice of medicine.
But it's a doctorate, right?
Right. You're right.
Right.
You're right.
So I'm just saying, like, there's doctorates all over the place, but
Yeah.
but that doesn't mean that you're a doctor in a clinical setting.
Right.
So that's what I think people need to really understand that. So when you get a doctorate online, or you get a doctorate that, the courses were primarily leadership or administrative, like, that does not mean you should turn around and refer to yourself as doctor in the clinical setting. And that's what I think is so frustrating and needs to be kind of talked about. But you often feel like you can't have that discussion, freely, because you just see, like, angry eyes at you. And I know that there are a bunch of, APPs that listen to this, and I like you said, we totally respect that role in the clinical setting, but I do think that it's okay to have these discussions and kind of just talk about being, really genuine and authentic with our patients, so they understand who's taking care of them. Because I do think that's really important for people to just understand the different roles of people on the healthcare team, all of which are valuable, but also different.
Right. And celebrate your credentials, and let the patient know that you're highly qualified to care for them. So if you want to put those credentials on a lab coat or discuss it with them, do that. But when it comes down to it, and you drove this point home so well a moment ago, Rachel, that patients believe when they hear the word doctor that it means something. And we can't move off that point, because that is their belief, that this is somebody who went to medical school, was trained in the specialty that they're in, and went through the things that doctors go through. Having a doctorate degree in something else, including a healthcare field, is not what they think they're receiving. Not that it's bad, not that it's less than, not that it's not valuable, but they should know exactly who's caring for them.
Do they call you doctor when you're working on a shift, Rachel?
Yes, they do.
Doctor,
Right.
doctor. Listen, let's do last one. Facing malpractice suit, sue your CEO and board. That's going to get you an extension of your contract for sure. This is by Robert Durlett. Robert has been around a long time. Robert has been a pot stirrer for a long time. He's in California. He's done a lot of work that makes you kind of think twice. He got into trouble in California when his emergency department, which was a state-run emergency department, was one of the big places. They were turning away low-risk patients, patients who could go to the urgent care center because they were just overrun with patients. And so, and this was in the era of the idea that you couldn't turn away patients. So they would do a screening exam, determine that you don't have a medical emergency, and normally in the emergency department, they do a screening exam, determine that you don't have a medical emergency, and still treat you. Well, if you do a screening exam and you determine you don't have a medical emergency, your obligation to that person is technically over. So what he would do is he would send them to other clinics or things like that, or and he got a lot of heat for doing that, which was in fact he met the letter of the law. That's and there was a capacity issue for sure, and he tried this alternative where but his colleagues really jumped on him for doing that. They thought it was cruel and and not nice and the like. But in any case, he wrote about in this case, this is he and another physician wrote this in EM News. This is March 2023. That's how current we are on our material. The gist of this is that if there is severe understaffing, or if there's fragmented hallway care, or has the is the ER adequately staffed? Are you an employer or a contractor? That'll determine who's going to get the hit if you're not adequately staffed. Has the hospital closed inpatient units to save money while continuing to admit elective patients? And as a result, you're holding these patients down here. Sometimes mismanagement crosses the line and becomes negligence. He also points out that metrics can be gamed to make the department look good and please the CEO. The unsupervised PANP issue is this money-related issue that comes up in these cases as well. EPs complaining about safety and other issues may get fired. Not in Arizona anymore. Not thanks to Amish
not
Shah.
for 6 months.
The need for a Hippocratic oath for administrators. Kevin, you may want to bring that up to your administrator.
Yeah, thank you so much for the suggestion, Rick.
EPs need to make the issues known through their professional organizations, engaging with the media. We must raise the roof if we see a patient in the hallway and they're experiencing decreased levels of care. And finally, we advise EPs named in a lawsuit as a result of their hospital's gross negligence in providing the ED with resources to sue the CEO. Have you ever heard of that happening? I kind of conceive of many opportunities where that would happen, where the physician basically gets in one of many ways compromised by the lack of staffing, the competency of the staffing, the holding of patients, all of those things that are really not uncommon in emergency medicine. And with, you're asking me to see too many patients. The hospital has not provided a backup system for emergency department patients when they're all employed. There's a litany of things that can make it look like you were not provided the reasonable support to provide care in the emergency department.
Yeah, I think this is an interesting way to apply a third-party claim. So I've seen a lot of third-party claims, Rick and Rachel. Rachel, I'm sure you have too. Rick, I'm sure you're aware of them, where there's, someone, and I've seen it medical malpractice, where you realize, wait a minute, I'm sued, but the person who really carries the burden of the negligence wasn't even named. Well, I'm going to name a third party and join them in this suit because they're really the ones who have the liability and they were overlooked by the plaintiff. So yeah, I've seen that, but to go to the hospital and CEO, certainly you can do something, but just because you can do something doesn't mean you should do something. If you feel strongly about it, you feel that you should, well, of course you have the right to do that and you can. But I will tell you, remember, they're held to the same standards, and remember the elements of negligence would have to be met as well. So did that administrator, did the hospital, they have a duty? They probably did. Did they breach that duty by not meeting a standard of care? Maybe you can make that argument. Ultimately, were there damages? Well, the damages were defined in the case against you, so the damages are clear. But what about direct and proximate cause? Was their negligence the direct and proximate cause of the damages that are alleged? I think that's going to be pretty tough, because what given day is there not some degree of resource issue within an emergency department? So I think that's going to be pretty tough to prove and get a jury to believe.
Yeah, Can I read the beginning of his article? Because I'm curious, if this really seems like, I feel like he was trying to paint the picture of some, day that went wrong in the emergency department. And I was reading it and thinking like, sounds about right. So I was just curious what you guys think. Can I do that?
Yeah, go ahead.
So it says, a plaintiff's attorney recently asked me to review the case of a young man whose appendix ruptured while he laid vomiting on the floor of an ED waiting room for 12 hours. Okay, not ideal, but and the ED was severely understaffed. Physicians were hours behind and nurses were overextended. One nurse was caring for a dozen sick patients in a noisy hallway. The hospital had throttled admission so the hospital CEO could save money by closing inpatient units. Meanwhile, the hospital profited by continuing to admit elective patients. Contrast that with ED patients waiting to be transferred to an inpatient bed, lying on gurneys in the hallways, thirsty, hungry, and forced to urinate in a urinal or bedpan in front of others. I once asked an administrator how often he comes to the ED to talk to staff. I avoid that place at all costs, he replied. I might get some terrible disease or be spit on by one of your psycho patients. I thought, yeah, that sounds like the ED, right? Like, I feel like he was trying to paint a picture of like, what an out of control ED, but it just seemed like an ED to me. I don't know. Maybe he was just trying to paint a typical one.
Well, I think it's a double-edged sword. You paint a typical ED as, see, all of these are horrible. It's not our fault. It's the hospital's fault by under-resourcing us. Well, you've basically just undermined your own case because this is not egregious. This is the way emergency medicine works to a certain extent. If it is horribly egregious, and I tell you what, where I think the claims will come that may have some legitimacy, and I think I've heard some rumblings of this, was during COVID.
Right.
And some of this came out in the news. Some of the facts came out in the news with the wrongful terminations of people who were making these claims. But I think under those circumstances, you can say, wow, we really didn't have all the things we needed, and they had the ability to provide it. But on a standard run-of-the-mill, busy, chaotic emergency department, how many jurors are going to say, yeah, I've only seen those that are well controlled. I've never had to wait. There was nobody yelling or screaming. There were no intoxicated people there. How do you make the argument that, like you said, that somehow a crazy emergency department isn't the standard?
Right.
Well, you're using standard of, I don't, when you use the word standard, I almost want to add to it of care. And
no, I don't think it belongs there. I'm just trying to, with this argument, I think he's trying to say, well, you can turn around and say the blame goes to the hospital for creating this like unsafe working conditions. But if that's just how emergency departments function everywhere, I think it weakens the argument a little bit, but maybe not. Maybe it's just every hospital is so greedy that every hospital is to blame.
I mean,
and you can point the finger at the hospital in every case.
He painted a really nice paragraph there. And can you envision a jury of 12 reasonable people? The patient was waiting in the waiting room for 12 hours. Well, what is the line? Is it 6 hours, 8 hours, 10, 12 seems unreasonable. And then you add some of these other things. Mary Jane called in sick and Bill called in sick, and they do that every weekend kind of thing. And
see, I would rather use those facts to mitigate the clinical team's liability a bit. Hey, this was a crazy day. In some cases have successfully shown that, well, wow, I was taking care of 10 patients simultaneously, and try and bring that information into a case. Other cases, people have said it's not admissible. This is one person, one clinician, one patient, that's it. So, but I don't know that I would necessarily try and make the argument that this frustration, which is global for some people, that every emergency department is hard to work in because people could do more to make it easier. They're globalizing it. It's just not that simple of an equation. I'm not saying that because I'm a CMO of a hospital and a group of hospitals. I am saying that having practiced emergency medicine for 25 years and knowing that this calculus is very complicated. And even when you are appropriately resourced one day, the next day, the wheels come off the bus. It's a moving target for sure.
Okay, guys, I think that's what we have for this month. There's a bunch of other stuff coming up that we haven't done. And they're lined up for next month. 4 or 5 people who
that was fascinating. We just got the CMO side. I want to bring that one back.
Bring it back.
Go to it.
No, we'll take it next time. We'll do like a debate next time.
I will be on vacation.
Oh, bummer.
No, happy to.
Whenever that is.
Happy to. I'm glad I've lived in a few different worlds, so I feel like I've got a pretty well-informed opinion, as I know you do and I know Rick does. So it'll be a good discussion.
Thank you guys very much. I appreciate
right.
it. Enjoyed it. Thank you. Thank you.
Thanks,
Thank
Rick.
you. We'll talk
Thanks.
soon, because we're gonna, I keep on telling Rachel, we're not gonna be doing this at the end of the month anymore. We're gonna, get caught up, and
Oh
here we
yeah.
are on the 28th of the month, doing March.
I've never heard that before.
Thanks, Rachel. Thanks,
I'm gonna
Rick.
do better. Bye-bye. See you all.